Discuss the advantages and disadvantages of randomized control trials. It's because why is this the only effective method known to control selection bias? Because it allow this randomization. What it does, there is random allocation. It ensures each group is similar in all aspects, known or unknown, except for the intervention. Suppose you are testing a new antihypertensive drug. Unknown confounders like sodium intake or stress levels may influence BP. That's why randomization balances these out across groups even if you didn't measure them. That's why it controls selection bias. But unlike observational studies, randomized clinical trials don't require you to identify or measure every confounder. Randomization handles it, whereas in observational studies you have to identify and measure every confounder. We know there are two types of studies. One is observational and experimental studies. Then comes under observational studies we have descriptive and analytical. If there is no comparison group, then this is descriptive. If there is comparison group, then there is called analytical. For example, in descriptive we have case reports, case series, cross-sectional surveys, whereas here we have ecological studies, whereas we have case control cohort studies and cross-sectional studies in analytical study. Now coming back to our topic, so it controls confounding bias without adjustment. So it controls it without the need for statistical adjustment, because groups are equal at baseline. Any difference in outcome can be attributed to the intervention. In a trial, for example, testing aspirin for myocardial infarction prevention, baseline cholesterol, for example, age, smoking, they are equally distributed. So you don't need to adjust for these using regression, because we know we control biases with the method of regression as well. Then it facilitates blinding, that is it facilitates effective blinding or masking. Why? Because when neither the patient nor the investigator knows who receives the treatment versus placebo, bias is reduced. And blinding is crucial in outcomes like pain, where patient belief can strongly affect reporting. It maintains advantage of cohort studies. So what is it? Because like cohort studies, RCTs track outcomes after exposure or intervention, reducing recall bias and allowing temporal clarity. For example, in a trial assessing chemotherapy impact on survival, outcomes are observed in real time after randomization. It ensures cause comes before effect. Another disadvantage is complex and expensive, because it needs rigorous design, monitoring, ethical oversight, blinding mechanisms, and long follow-up. For example, there was this trial called as ALLHAT trial, which was testing antihypertensive drugs. It costed us hundreds of millions it costed, and spent years with tens of thousands of participants. That's why budget, time, manpower, ethical approvals often make these RCTs impractical for every question. There is one thing, that there is this disadvantage, lack of representativeness. People in these RCTs, they are often healthier, they are younger, and they are more motivated than real world patients. For example, in a diabetes RCT, patients with multiple comorbidities or poor compliance may be excluded, so results may not generalize to public hospital population. That's why it is called what is called as volunteer effect. and volunteers also differ from population of interest. Why? Because people who agree to participate often differ in socio-economic status, health awareness, disease severity. For example, in a COVID-19 vaccine trial, volunteers were mostly urban and educated, while rural patients were unrepresented. So, real world vaccine hesitancy or varied responses in other demographics aren't reflected. Third is ethical limitations can be immense, so you can't randomize harmful or essential exposure. Withholding a proven treatment or exposing someone to risk may be unethical. You can't do an RCT on the effect of smoking in pregnancy or on denying insulin to diabetics. So RCTs can't answer every question, especially those involving serious harm or benefit. So normally in observational studies, we do statistical adjustments. For example, regression we do to control for this confounding bias. But how do randomized control trials control confounding without adjustment? But we don't do adjustment in analytical studies. We do it just by randomization. When you randomly assign participants to intervention and control group, every confounding factor, both known and unknown, is equally distributed in the groups. That means the only systematic difference between the two groups is the intervention. So any difference in outcome can safely be attributed to the intervention, not to the confounders. So in a nutshell, RCT is control confounding bias inherently at the design stage via randomization. So you don't need to statistically adjust for confounders like in observational studies. And in observational studies, be it cohort, case control, cross-sectional, we know treatment exposure is not assigned randomly, so confounders may be unevenly distributed across exposed versus unexposed. So you must measure and adjust for them, otherwise your conclusions will be biased. Because for instance, in a study on aspirin reducing heart attacks, patients who choose aspirin may already be eating better or doing exercises and seeing doctors more often, being healthier at baseline. So that's confounding. So we have to do adjustment for this confounding in observational studies. We do it by stratification. We divide it into the subgroups. We do multivariate regression analysis, which is the most common method. In this, there is statistical. It is like a statistical modeling, like logistic regression, Cox regression, linear regression, to adjust simultaneously for multiple confounding variables. This helps us isolate the independent effect of the exposure. So we have 3-4 methods. One is I'll tell you. One is this in observational studies. One is this stratification. Another is multivariate regression analysis, which is the most common method utilized. Third is matching. Fourth is propensity score methods. So stratification, multivariate regression analysis, matching. So S, M, and P. Propensity score method is a new modern technique where you model the probability of receiving the treatment based on confounders and use that score for adjustment. And there are other advanced methods, that is instrumental variable analysis, IVA, which is an advanced method now. So to summarize, we have methods like stratification, multivariate regression, matching, propensity scores, and instrumental variables for this observational study. So key takeaways are this: in observational studies, confounding is handled by measuring the variable and using statistical or design based methods to adjust for them, unlike RCTs where randomization balances them automatically.